And the first work stream is preparing the EDAM. This is our project form that we're going to discuss today.
Hello everyone, my name is Simran Shafiq. I'm one of the neurosciences pharmacists. So there's two things that I'd like to talk about today. The first is Blue Spear itself. We've used the 5S processors and the work and applied that to try and streamline the information that's actually on Blue Spear. So what we've done is, firstly, we've actually streamlined the way the drug lists are actually presented. So we have, rather than neurosurgery, we have now L24, L25 discharge covered to make it easier for the medics when they are populating the EDAN. And then we've also streamlined the actual medication that's on the list, so the commonly used medications and what's actually in the discharge cupboard. And we think by doing this, we've improved the quality of the information on the EDANs, we've reduced the time it takes to populate the EDANs with the discharge medication. We're also hoping that it's going to reduce the overall time as well, which I think the figures show that it has already started. And then finally, Sarah O'Neill, who can't be with us today, who's one of the pharmacy technicians, she has single-handedly used the standard workflow and pushed the discharge cupboard from an S1 to a level 4. So that means she has streamlined all the, I don't think I've got the guidance. She's produced some guidance for the staff on the ward, so there's pictures on there, there's writing on there, to try and make it easier for them to actually take the information out and leave copies of the discharge to make sure we have an audit trail as well. And again, we don't have any figures to actually show what's happened with that, but we've got anecdotal findings that the number of EDANs that are bypassing pharmacy has actually increased during this the last 30 days. But now, from now onwards, we're going to try and log that data so we can report at another 30.
So my name is Karen, I'm the Band 7 on Ward 25 and I'm also a process owner. This is our target report. We're not going to look at every single section here, but we are going to just concentrate briefly on 4 of the sections. First section we're looking at is the lead time. So initially we had a baseline of 401 minutes, and that was decision to discharge from the ward round to the actual EDAN being ready. Within our IPW week, we achieved a target of 125 minutes there, but that was over just 2 patients, and we were aware that it was limited because it was running over the week. Currently, we've achieved a target time of 154 minutes overall, but then we split those down yesterday. So out of 15 patients, we split down into the patients that are being pre-populated, which is where the CNSs or the Ward 28 or other staff or HDU step-downs have actually started the EDAN, and the ones that haven't been pre-populated. The ones that weren't pre-populated was getting an overall time of 316 minutes, which is still an improvement of 21%, but the pre-populated ones, which were 9 out of 15, we achieved 88 minutes, which was an improvement of 78%.
Very good.
So we also wanted to look at the quality defect of pre-population. Initially, pre-population. So initially, none of the EDANs were pre-populated, so we had 100% defects there. Again, as I've just said, the figures that we've just collected for the 15 over a course of one day for both wards, 9 out of those 15 EDANs had been pre-populated, which has given us an improvement of 60%. We've still got the others to work on. Quality defects, which was doctors getting instructed in trying to prepare the EDAN, has been at 100%, always at 100%, because the medical staff do the EDANs at the nurse's station. There's the telephone going on, there's all the staff around, people are asking questions. We've tried to move them away from the area, sometimes with success and sometimes with not some success. But out of the ones that we've been looking at, if we've moved them away from the area, one out of the eight was interrupted, but the other 7 weren't interrupted. So they had a quicker time. If they stay on the ward, they're still interrupted 100% of the time. And then the last one was just the final one, the setup reduction time, which was the clinical time spent preparing the EDAN on the day of discharge. And again, we've split it down for the pre-populated EDANs, the ones that have actually got some information in it and the ones that haven't. The ones that have got no information in, we're very static. It's 29 minutes is where we're coming out at. 28 minutes was the baseline initially. But the pre-populated ones are coming out at 6 minutes per EDAN, which we said if the other the other 6 had been pre-populated, it would have saved the medical staff 138 minutes over that day period. So it's just where we're at now. Just some pictures. We've started using a check sheet for the ward rounds, so that when the doctors actually say this patient's for discharge, it's just checking really roughly whether there's anything we need to pick up on, whether there are any other medication that we need to be looking at, whether there's any anticoagulants, whether they're reducing the dexamethasone and stuff. But actually the first picture at the top there is just to show that it's being used by the ward staff and being used consistently by the ward staff. There's a discharge board which is here, where they put on, and then the EDANs are changed accordingly, whether it's waiting for the doctor to do it, or whether it's waiting for pharmacy, whether it's ready on the ward, just so it's a quick glance and people are consistently using that. And this was to try and show that we've also implemented that none of the drug charts that come to the nurse's station, they all stay with the patient, and that's a clear desk with no, and it's working. We still have the added cups.
Yeah, we're still trying to audit that once or twice a week to see whether the charts are being read for a valid reason or not. So that's going to continue as well.
Okay. Just a newspaper, we're improving in all areas. Some we've completed, some we still need some improvement, but we're expecting that to be 100% complete by the end of the 90 days. And just success and challenges. The checklist is successfully used, and the nursing staff have got it embedded in. The whiteboards act as a visual aid, and all the MDT, even the physios and the OTs, everybody is actively using those.
And the pre-population of the EDAN has proven to reduce time on the day of discharge. And our challenge still is the medical staffing, the numbers that we have available to do the pre-population, and changing practice. So getting the medics to move away from the nurse's station and go somewhere quiet to do it. But we're really pleased with our work so far.
Yeah. So thank you, and we'll see you again in another 30 days.
That's great, excellent. You'll have noticed as you've been talking, more and more people are coming in. So the word is spreading Can you do it again?
They did really well. They did really well. Yeah.
Thank you ever so much. That's really encouraging in terms of some of the metrics and the improvements that we're seeing. I know the way we do this, we need to save up the questions until the end, but I'm sure there will be some, but you're able to just stick around. So the next team to present, if we move on here we are. Team. Okay, when you're ready, guys.
Well, good afternoon, everybody. Well, my name is Matthew Spence. I'm a pharmacy technician. I'm also the pharmacy department's quality improvement practitioner. I was fortunate to stand up in front of you a couple of months ago with a team called PharmaCast on behalf of Joe Buck. I'm now looked, and when I presented that, I said I'd like to come back with the team that I project manage, flucloxacin. So I'm very privileged to be stood here with the team today. So flucloxacin is a lead program that we run within pharmacy. It's lean education and development. Just a little bit of background about fluclox. So the drug is flucloxacin IV 2 gram. We produce this within pharmacy, within our PMU unit. This we produce to save staff, nurses time on the wards, and then allow them to be more patient facing. So without further ado, I'll hand you over to the team.
Hi, my name is Steph and I'm a pharmacy technician. So a number of topics were discussed for our lead project, and it was thought that 2 gram IV flucloxacillin best suited our skill mix. It was prominent and had the potential to benefit a number of departments within the trust. The current process involves a pharmacist writing an order and faxing that to the aseptics department for triage. If it's urgent, aseptics will dispense it, otherwise they then fax the order to Morehouse. Morehouse process the order, send the flucloxacillin to aseptics, who then arrange for delivery to the wards. The faxing in itself is time consuming. It's clear that there's a lot of wastage due to the number of emails that used to be sent out offering a surplus stock. We are aware that there will always be some wastage of this drug due to batch production and the department not risking running out of the medicine. So flucloxacillin is an unlicensed medicine and it's supplied as a stock item for named patient use on the ward.
Hello, my name is Amy. I'm a pharmacy support worker at the St James's Hospital. We started our project with questionnaires as our initial data collection to find out the current process people use for ordering and their thoughts on it. We spoke to pharmacists, pharmacy support technicians, nurses and various ward staff. As you can see on the slide, there were questions that we asked. How many times a week, on average, would you order IV flucloxacillin? Do you think the current way of ordering works? Do you feel that our fridge is overstocked in the IV flucloxacillin? On average, how much IV flucloxacillin is wasted each week? If a patient no longer needs the IV flucloxacillin assigned to them, would you try to find another ward or patient need it before it expired? How would you dispose or deal with the out-of-date IV flucloxacillin? As a part of our root cause analysis, we used the 5 whys, the fishbone tools to identify there was no clear process. There was duplication, faxing and over-ordering resulting in an overproduction. We believe this to be lack of clarity and communication between various departments due to many steps in the process.
Good afternoon, my name is Matt and I'm a pharmacy support worker at the LGI. After the questionnaires, we then carried out an audit which took place on J19, J20 and J21 over a period of 3 weeks. With daily visits to the ward, in this period we found that approximately 30% of bags were wasted over the 3 wards. The audit showed that the 3 wards, 362 IV flucloxacillin bags were supplied over this period. 57 of these bags definitely expired. 51 bags could not be accounted for and we presume they were expired, resulting in 108 bags expired or unaccounted for. If we extrapolate this over the trust for the 3-week period, a total of 1,934 bags supplied. If a third of these expired, that means that 580 bags. Extrapolate this over the 12 months and over 26,000 bags of IV flucloxacillin were supplied based on a third going to waste. This is nearly 8,000 bags. Morehouse is a pharmacy warehouse unit situated in Hunslet and it's home to the PMU unit, Pharmacy Manufacturing Unit. This is where flucloxacillin and other products are made. It also is the home of the medicine procurement and where the wards are topped up from. In late 2016, the PMU underwent a refurbishment, shutting down their unit for a number of months. Due to this shutdown, we have based our figures on the first half of the year for a true reflection. The pharmacy price for a bag is £5.13. This is based on the average price and the usage of PMU produced bags, and also BAF ASU, which is a supplier we use to help maintain demand. The Morehouse actual price is £7.86, which includes Morehouse calculated overheads. Based on these 6-month figures, we supplied over £64,000 worth of IV flucloxacillin. This is nearly £130,000 of supplied IV fluclox over 12 months. Based on the 12 months figures and the Morehouse figures including overheads, our projected waste cost for the trust for an average 12-month period is just over £64,000. After discussions with the stakeholders, they feel that a 20% waste figure is more realistic, which is likely to be around the £4,000 mark.
So a few of us spent the morning at Morehouse, and this was an interesting visit for those who've never been or inside a production unit. We timed the different parts of the process, which you can see. So we timed each part of the process from start to finish, so including setting up, gassing, making, checking and releasing of the product. And we used the timings to work out staffing costs, and we picked the midpoint of the lowest band possible that could perform the task.
The total cost of one batch which is 40 bag, was £36.39 staffing time, which works out around at 91p per bag. It costs over £24,000 for staff to make a year's worth of fluproxycillin. As we've estimated, a third of bag goes to waste. This means just over 8,000 in paid man hours is wasted. This factored into the overall 64,000 figure which Matt mentioned earlier. But factoring the time element, this takes approximately 4 hours to produce a bag. This does not include the 3-day quarantine time before the product can be released, which estimates 885 working hours which are spent producing the product which will expire. This equates to over 23 working weeks of the year which someone's product is going to waste.
After looking at the pharmacy reports, we chose J20 as a water trial on due to them being a regular high user of the 2 gram fluproxycillin. We have written a proposed SOP for how the pharmacy ward staff were to order fluproxycillin. The SOP would need to be tweaked if we were to roll it out department-wide. We discussed our ideas with proposed SOP with the appropriate stakeholders and begun our trial and stopped holding supply from the dispensary at St James's. Unfortunately, due to the circumstances beyond our control, there were no patients on J20 who averaged 4 bags per day, which equates to one patient normally having fluvox 2 gram IV on the ward at any one time. This shows the variation in the demand for this drug, which we feel our proposal will help address.
Moving forward, we aim for a new trial to begin at the LGI following the process outlined on the slide. We feel the process needs to be streamlined and we need to reduce the amount of faxing and people involved in the process. So hopefully an electronic non-stock order can be raised, which will be sent to the dispensary and the designated person will dispense that. It would then be checked and then sent up to the ward, and there's a designated person to order replacement supply from Morehouse. So one proposal is of the electronic non-stock ordering. These orders are printed direct in the dispensary, so it reduces the amount of faxes being sent and also the amount of paper being wasted. We also recommend looking into whether ward technicians would be able to order the fluproxycillin. At the moment it's only pharmacists who are authorised to, so therefore this would help pharmacists to utilise their time. And we believe our recommendations deliver a leaner, more streamlined process. We have better and more accurate compliance with unlicensed medicines, better stock control, and overall less wastage of cost, time and medicine.
Lessons learned from this project. This has been a much larger project than we had anticipated. We overcame the resistance to change by discussing and clarifying our recommendations with the appropriate stakeholders and involving the correct stakeholders at the right time. Thank you for listening.
Excellent. Thank you very much. It is terrific to see the impact of looking at waste, isn't it, in terms of the cost, and I think we all sort of took a sharp intake of breath when we saw the extent of the potential savings that you've identified from better all of the work that you've done. And I know I've been to Morehouse and seen that unit, and it's really good to see you looking at how we can develop and improve. So again, I'm sure there'll be questions. Now my apologies, I'm just off up to Chapel Allerton to see the staff up there after yesterday's event, so if you would excuse me, Yvette will round off and deal with the Q&A session, so thanks very much.
Thank you.
Don't panic, it's a code red. Now don't be panicking, take your time, it's just a code red, hang on, I'm coming. Right, so we can, code red. Hello, my name is Helen McGarvey. I'm the lead nurse for clinical quality on the adult critical care units. I'm not a process leader, and I have to say I don't actually know what that is, because I'm not within the Kazon or the Leeds improvement methodology and process at the moment. I've been asked to come and talk today about Code Red, and this is something we've developed within adult critical care to improve how we respond to an incident. So, but it's taken from the Virginia Mason and the Toyota in terms of stop the line, and we interpreted that as calling a code red to make us stop and think about what we're doing. So we started this work earlier last year. Why did we do it? Well, we were getting particularly bothered about the number of our healthcare associated infections, and in particular our CDIs. We also were getting a bit bothered by the fact that we couldn't seem to get our RCAs completed on time, and we were forever chasing our tail. Our clinical staff, our bedside staff, weren't involved in those investigations, so they weren't empowered, they weren't involved in the sharing and the learning. And so we thought, well, let's have a look at this and see if we can change stuff. So we came up with Code Red, and this is a response to when we get notification or that we know that an incident has happened. And using quality improvement methodology, we started small, so we identified we wanted to use healthcare associated infections, and in particular just CDIs. And we did that because we wanted to trial the tool, we wanted to test it and see whether it would work. And the idea is that at the point of notification or awareness, you call key individuals to bedside within a 4-hour timescale. That might sound very challenging, and it is. But at that then full MDT, you start, you might not complete, but you certainly start your investigation. So this is what we proposed, and this is what we started trialling out last year on one unit. So we started small with one specific thing. This is the schematic. This is version 4 now, and there are some if you want some. So this is our version 4. It's changed a bit over the times, but it's basically the staff nurse looking after, or whoever's looking after that patient, knows something's happened. Will have had a message, or they know themselves. They'll normally tell the nurse in charge, and that nurse in charge then calls the code red. And at this, we then start to call in all the key individuals that we know. And we've evolved this over the past year, as you can see, into 3 major categories, which are HIAs, Cat 3s and 4s, or Cat U's, and a serious fall. Although within critical care, we do an investigation for any fall, because that's something that really shouldn't be happening with our environment, with our staffing level of observation. So we asked those people, it says 2 hours on them, so the idea is that we call this, as I say, within office hours normally, but what has evolved is that now happens during any time. So what have we found out? Well, in the process of testing this out, and it now runs across all of our critical care units, and it applies not only to HCIAs, but also, let's say, to falls and other pressure ulcers type incidences. It allows for an extremely timely review of the patient, i.e. are they safe? Are we doing everything we know we should be doing? So if we check the drug chart, if we check the falls assessment, or the cot size in place, is the bed at the lowest level, whatever else we should be doing, is that what we are currently doing? Our expectations and engagement from IPC and all the unit-based staff has absolutely changed. And the main thing I think is one of the really positive benefits is that the staff at bedside now go, so when are we calling code red? Who do I need to call? So what do I start to need to do? And that for me is absolutely taking ownership of this. They recognise its importance and they want to do it, they want to understand. We're really quickly enabled to identify what lessons we need to learn, so what might we not have done so well, but also we are now moving into celebration and learning from excellence. So what did we do well? Because that really is so important for staff to hear that in the majority of the care that we do, it's excellent, it's brilliant, and on the small occasions we have hiccups. The added benefit is those nurses can then talk at the next handover or the next coffee break, and that sharing is learned there and then. It's not waiting for an RCA meeting 6 weeks, 8 weeks down the line, which happens remote from the area, and they don't hear about it. And it means also they're involved in these investigation processes, so they are encouraged to ask why, and why, and why, and why, and why, and why, or what else. So the sense of feedback has been absolutely positive. I was hesitant at first when we started doing this. I took a step back about 4 or 5 months ago, and this is now owned by the intensive care units, so they call their code reds. I now come in as a support as opposed to leading it, which I've previously done when we started out the project. So again, it's passing this down, empowering other people to share this on. There's a sense that something important is going on, that something has happened, and we need to have a sense of that. Our RCAs are submitted on time, and that immediate changing learning has actually started to change behaviours in terms of challenging people to wash their hands, or making sure we've got the severity scoring known about and recorded. Or where we put our terminal cleaning forms, that was a big problem that we found. We just didn't know whether the bed space was clean when a patient was going into it, which can be problematic. It is challenging to achieve all the people that we want to be there actually within that time frame. And even within critical care, we're very lucky. We have a lot of our staff there all the time. But to get IPC there, to get facilities there, is really very challenging. So what we're morphing into now is that we will still hold that initial code red, but then we will book an RCA meeting for the 5 days to make sure that everybody is still having that consultation and collaborative investigation approach. So we seek additional advice and support as we need it. So next step, as I say, it's still evolving. We're on to iteration number 4 now. I'm sure it'll tweak over further time. And then the next stage is to use what's called a code amber. And this again is a more localised response for things like non-serious falls or category 2 pressure ulcers or a medication incident where the staff already do investigations, but again it might not be the next day, it might be 2 days later, and people forget and move along. And that's it. Thank you very much.
So thank you very much, Helen. Please stay near the front if you like, but I think you've demonstrated there something really important, which is that you're learning very quickly from when things go wrong, and what's more, you can do something about it immediately. And I know, because I get a text every time we have a case of C. diff in the organisation, that I haven't had a text about one of the crit care units, it feels like, for the gaps seem to be getting a little bit bigger.
Yeah, it's a bit bigger at the moment, a few more weeks
Yeah.
in between.
So that hopefully that means that some of the things that sometimes we find when we do a root cause analysis, there's nothing we could have done differently, and that's okay. We know some things will happen, but if there are things that are preventable and that we're learning from them, and I guess, as you say, it's the staff who are there. You know, if a patient develops C. diff, it might have been something that happened a few days ago that's predisposed them, but actually the learning about it is huge. So thank you very much. We've heard from 3 teams. We've heard from L24, L25, and the great improvements there with your EDANs. We've heard from the flucloxacin team about the real improvement in the process for ordering IV drugs. And we've heard from Helen on code reds and learning from incidents. So now's the opportunity to ask one another questions. So has anybody got any questions for any of the teams? Helen?
Yes, the neurosurgical team, in terms of, have the patients noticed any change? Is there any, do they see that improvement? Because that's a phenomenal improvement, you know.
It's difficult, isn't it? Because they're I think there's been some surprise in some of them that have been able to leave by 10 o'clock in the morning. Which is improvement. That's still tiny, but you start with baby steps, don't you? So they are surprised, but it's difficult really sometimes whether, I think you're right, people expect to be leaving later on in the day. We are getting them out before lunchtime, and there is some surprise in their cases.
There was a lot of links in the complaints about, why do I have to wait 7 hours for my tablets when I was told to go? So hopefully we should see a change in that, because it's they're going much earlier than they were. So hopefully that should reduce as well.
Can I ask about the junior doctors then on that same matter? Because I think it is one of those heart-sink tasks for junior doctors, and so for the ones where they found that they'd been pre-populated, have you had any feedback from them about, blimey, that was
I think
good?
some of them are thinking of fully running with it, and they come down to the bottom of the water. They use the EDAM, and when I've sat there myself and witnessed as we finished the popping and going, can I just do an EDAM? And I think some of them are still thinking they're needed on the ward, and no matter how many times we'll say to them, we can still find you, we know where you are, and we will come and get you, they will sit at the desk and fill them in. But having said that, the CNSs have run with it, with pre-populating. The head injury nurse and the vascular nurse and the others at the all put their bits of information on it, so it's there. So we don't have to go chasing that information.
Have you had a surgeon put anything on it? Dare I ask?
No comment.
Because that, we've got the urology team doing some EDAN improvement work as
Well,
well.
the pharmacy team are actually meeting with the urology team on Tuesday and with some of the senior pharmacists as well to discuss what's happened there, what's happened here, because I think they're running out of steam a little over there, so we're hoping we can motivate each other.
But
So we'll see.
equally, Andy, you do the EDAMs, are they?
There was one earlier this week that what a CNS had started, and I did not change it. The EDAM was so rich in detail, and it included everything from admission pathway to events that happened to the follow-up details, and I didn't change one word. I just to check it, put the medication on, and it took me less than 5 minutes from beginning to end because of that detail. And that's because the CNSs are capturing this information and putting it in their letters and on their records, but it's down to just transferring it as well into the blue spear system, so it's there for us, and even if we have to change certain things and make sure it's accurate, but it's a lot more efficient.
We're starting to get the surgeons they're doing EDAMs in theatre and Gilbertstone, but that's kind of outside this process. So I don't think it will be an enormous leap for them to start doing them for some of the other patients. So
It is hard sometimes. We're always aware that filling information in too early, there's a risk that information will change by the time of discharge. So that's why we're always aiming to check it at the end. But like I said, it's easier to check something that's completed than to start from scratch and look back in 4 weeks of critical care and operations to try and create a storyline.
So the step downs from critical care, they've spent weeks on critical care, and then it gets to the EDAM, and you have to plough. Not me personally, but to plough through to get that information on. Whereas now when they're coming from critical care, we're asking them, and again, sometimes it's staffing, but the nursing staff on there can do it, and we're asking them just to put the basics down so that we've got a line what's happened while they've been down there, so we're not chasing all that as well.
Good. Okay. Any questions for our pharmacy colleagues? Since you did your quick trial of it, have you managed to find any wards yet where you have had reduced wastage?
Not as yet. We're planning on doing something over here at the LGI in the coming weeks, so hopefully we're involving the correct stakeholders and moving forward. So hopefully we'll come back in 6 months and we'll have some great information to share with you.
We use it a lot.
We use a lot of flu bottles.
And lots.
Well, great. So you've got some volunteers, right? And then, okay.
Is there any of the medicines that you think you might be able to identify towards a similar process?
Well, hopefully, yes. So this is Fluvox is a starting point that was prominent within the department, and then hopefully we can use the same process with other medicines moving forward.
Okay, great. Thank you. And any questions for Helen on Code Red?
Your NDT that assembles, who's involved in that then? Is there any minimum requirements or?
We certainly like to have the nurse looking after the patient, the nurse in charge, either unit doctor or a consultant, because we normally have both of those on site, certainly during the day. And the pharmacist, if they're currently there, we would like them to come. IPC, we call the IPC nurses to come up. Estates we like to get there, but often depending on the facilities they can't do. But if we would also include that if the housekeepers are there, we will ask them to come and join the groups, personally for healthcare associated infection ones. So the unit matron. So the sort of bare minimum is your nurse, your doctor, and the matron. We can still run it in that sense in terms of answering the patient safe. We like to get as many as we can. Partly because we're privileged in having staff around, but we realise that's a challenge.
Do you include family?
We don't exclude them. If they're there, we're happy for them to stay and be part of that discussion, because normally with CDIs or other infections, they've either been in isolation for a day before we get the notifications through, so they have an awareness. And we're open in that sense. We're looking to see what we're doing well or what we're not doing well. We don't exclude them. Because they get to know as part of the duty of candour anyway. So we don't sort of actively ask them to leave. We don't feel we need to do that.
So we spoke to you at the nursing conference, and you say Lana's looking at it, maybe something, because we'd be quite keen, but it's a big time commitment on the ward. But you said the same
We'd like to try to do that as well.
Taking this forward, to say we were sharing this at the nursing conference on Wednesday. I'm also over in Manchester next month at the safety conference there, doing a poster presentation for that. I've got a poster accepted for Kuala Lumpur if I can have £2,000 to make. As soon as I've got the bosses in the room. But as you say, what sort of...
I think you need to show some improvements before we can possibly...
No, I can find them easily. I can find some measures, no problem. But it's now feeding into work that Lorna Johnson, who's the head of nursing in the corporate side, in terms of she's been tasked to review how we do investigations, so it's feeding into that style and how we could adapt this for more or less any environment, but recognising that you obviously won't get this massive MDT that we can often pull together. But the essence is that stop and look, and is the patient safe? That is an applicable approach that you can probably apply to any environment, whether that's estates, facilities,
measurable expression.
Yeah. So that you'll probably see some drafts, because I know Lorna's sort of typing away at the moment.
And I think I think it is particularly important that you reassess the patient and say, are we still doing the right thing for the patient?
I was just going to add that, if we've got enthusiasts in the room that want to take that learning away and what you've been doing, it would be good just to see what components of it, even if it's not across the whole breadth, you could actually do to improve your own systems. Recognising what you said about getting the wider team there, but it is, the enthusiasm itself to actually want to try it will be great.
Very good. Right, has anybody else got any other questions or comments?
Just to say, Helen, it's an amazing piece of work that you've done, and absolutely, I think there will be the appetite to roll it out across the organisation. So, thank you. That's really good.
Okay, well, I'd just like to say thank you very much to all the teams who presented. The work that you're doing is really, really exciting, and it's showing that continuous improvement. And I think the important thing is that it breeds further enthusiasm, doesn't it? And to change more and to do more. So I think perhaps a box of Smarties in the doctor's room. Sorry, I meant tangerines.
No, it's not
sweets, I think is what I meant.
Right, well, thank you very much, everybody. I believe we've got report out again next week. Is that correct, Helen?
Yeah, and then we'll get on the 30th.
So, report out next week is at St James's in Bexley Wing, and we'll be hearing from from urology about how they're doing with their EDANs, and also they will have had an RPIW where they're looking at patients who go home with a urinary catheter in, and our process for having them a trial without catheter. I don't know if there's any other advertising for any other report outs.
We might have another improvement reporting out, so somebody's just asked about that today, so yeah.
Right. So yeah, and any other projects that you're aware of that people could report out on, please let us know, because we are trying to build these into not just the ones that are being supported by the KPO. Okay. Thank you very much.
We're back to a 12:30 start next week. So
12:30.
just a strange one today. It's 12:30, level 7 Bexley next week.
Thanks, Jimmy. Right, thank you very much, everybody.